my voice? Miss
Yes, we
Already,
can.
would you let? Okay. Thank you very much. This is the last but not the least session of the first day of virtual winter school program 2021. And I would like to welcome you to the oral pathology department. Also, I would like to thank all of my colleagues from the beginning of the today sessions till now. I am Dr. Shaki. Would you like to see my face? This is my face. And I have to wear my mask because I have my colleague here in the Path lab. And I'm oral pathologist. Originally, also, I am Vice Dean for International Affairs of the School of Dentistry. And hope you have enjoyed the sessions during recent hours. And at this part, we will have 4 presentations. At the first part, I will give you a short look of the oral pathology laboratory. And after that, my colleagues will show you some interesting cases in oral cavity. And they will try to make you familiar with differential diagnosis and how oral pathologists do during making a definite diagnosis. So let's start. Also, I would like to mention that my colleagues, Miss Banai and Mrs. Falahati will help us. They are our technician at oral pathology lab, and they will help us to moderate this panel. Okay, let's give you a short question. Do you know what kind of solution is necessary to be used after excision of a lesion to transfer a specimen from the clinic to the pathology lab? Please think about it. Let me wear my glasses. Please send your response. Send your idea in the chat box and I will check it later. Let me wear my okay. Let me make you familiar. Let's come closer. I think you know that the formalin solution, 10% buffered formalin solution is necessary to be provided in all dental offices, especially the dentists who focusing on dental surgery, minor or major dental surgery, because it is necessary to put the specimen after excision in formalin solution. You should put it in this solution to be fixed by the solution. After that, you are supposed to transfer the specimen to an oral pathology lab. Here, I will show you devices here and equipment here in our lab. Let's have a look at a specimen here. Please come closer. This is a specimen of a facial area of a patient. Can you see this? Okay, I think you can see this. Let me show the other side of this specimen. This is an ear of a patient excised because of an invasive tumoral tissue, a tumoral nest, and the medial aspect of the specimen. The surgeon has excised the whole specimen, including ear of the patient, and also surrounded by cutaneous tissue invaded by a lesion. And I think you don't prefer to look at it for a long time. The oral pathologist is supposed to have sections. Would you come closer? To have some sections here to provide section, dissect the specimen, and also provide the thin pieces of the specimen. because it is necessary to provide thin thickness specimens for processing. Let me show you how an oral pathologist provides such a cut of the specimen. You can see here we have tumoral tissue here invading all the subcutaneous tissue. This is a tumor of parotid gland. Yes. And now we have provided a slice of the tumor, and I will provide it better for the processing, and it is ready to go ahead for the other process. Let me put it in the formalin solution. It is necessary to preserve our specimen for upcoming processing in future. Okay, let me take the video and ask my colleague, Miss Banai, to show you and explain for you some details. Hello. Wait.
Everyone, let's talk about this processing of tissues in pathology lab. As Dr. Shaki mentioned, after that, we use tissue processor and tissue processor for processing tissues with different percent of alcohol and xylene and particles. After that,
sorry for interruption. How long does it take to process a specimen? Overnight. Yeah. It takes about. Sorry, do you have my voice, colleagues?
We cannot hear you clearly.
How about now? Do you have my voice? How about now?
Yes, we can hear you, but we cannot hear your colleague very well.
Okay, let me get closer. Okay, how long does it take to process a specimen?
about overnight.
Overnight, okay.
Yeah. And after that,
sorry, would you please talk louder a little?
Yeah. And after that, we can make paraffin blocks to prepare with cut sections with microtome. And we put tissues after process, and after overnight we prepare with tissue processor, and we have paraffin blocks with label.
Okay, thank you. Sorry for interruption. Yes, sorry for the quality of the camera, because we are trying to show you the details of what is happening in oral pathology lab, and I will try to show you some details. As my colleague explained, after providing the specimen, we put it in we put it in paraffin block to provide cut sections. Let's go to the other side of the lab.
And
what is this? This is a microtome.
This is a microtome, and we can prepare sections to put in warm water to make slides. And
okay, how does it work?
You can see, if you can see.
Let me get closer. Yes, yes. Yeah. Yes, and the thickness of the of the cut provided by the technician are about 4 to 5 microns.
Yeah, you can see. After that, we put this section in water,
mm-hmm.
and we slides.
Yes.
Um,
Microscopic slide.
Yeah, and after that, we choose tissues sections
Yes.
to go to staining steps.
Yes. And I think you are well familiar with the staining method in oral pathology and all pathology lab, including general pathology and oral pathology lab, which is hematoxylin and eosin, hematoxylin and eosin staining.
And for some cases, pardon, and in some cases we have IHC staining, and we use these techniques.
Yes,
in this lab.
this is great. We commonly use immunohistochemical staining to determine if it is a malignant or benign tumor, or even we use immunohistochemical staining to show the prognosis of some lesions. Okay, let's have a look at a microscopic slide.
Finally, we have this slide.
Yes, this is a microscopic slide that
we can see.
yes,
This,
we can use it. We can put it under light microscopy, and oral pathologists can use this kind of or other kinds of light microscopy to determine the which lesion you face with in the patient. Okay, thank you very much. We try to have a short review of what's happening in an oral pathology lab, and I think at the second step we have our head of the department, Dr. Mahdavi. Dr. Mahdavi, do you have my voice? Dr. Mahdavi.
Hello, yes, I can hear you.
Hello, thank you very much. I would like to introduce my colleague, head of oral pathology department, Dr. Mahdavi, and I know that she has provided an interesting case to show you and share it with you and share her knowledge with you talented students. The platform is yours, and I will join you in a few minutes. Thank you, Dr. Mahdavi.
Thank you very much for the nice introduction, Dr. Shakib. Share شده اسلاید من. So my apologies, there seems to be a technical problem. The IT teams are going to solve it as soon as possible, and I'll be yours with you again.
Okay, so let me show more details of our department until you are providing you are preparing your slides. Oh, you are ready?
I'm ready.
Let's be a few seconds.
Of course, of course.
Okay, sorry, Dr. Mahdavi. We are ready to hear your presentation.
Thank you very much, Dr. Shakib. Good afternoon to everyone. I would like to welcome you again on behalf of the Department of Oral and Maxillofacial Pathology to this scientific event. After the presentation of my colleague, Dr. Shakib, regarding the principles of the preparation of the pathologic slides, I'm going to share you some cases. Actually, in the upcoming presentations, my colleagues and I are going to share some cases which are important for a dentist to know with you. And I'm going to share you some lesions of salivary gland origin. Okay. As you know, saliva is secreted by some major salivary glands and a couple of minor glands scattered through the oral cavity. The major glands include parotid, sublingual gland, and submandibular gland. There are also some minor salivary glands scattered through the oral cavity. You can find them in the labial mucosa, buccal mucosa, floor of the tongue, floor of the mouth, lingual mucosa, and lateral portion of the hard palate. So I'm gonna present you some cases. Obviously, the more common and more important ones of salivary gland origin. The first case, which I'm gonna present, is a 17-year-old boy. Yes, actually, a young boy. He had a lesion in the lower lip. As you can see, it is a dome-shaped elevated lesion with a bluish hue. And the mother of the patient says that it was waxen vein. It comes and then heals by itself and then grows again. The surgeon performed a biopsy from the lesion. And as you know, the histological feature of the lesion are somehow the gold standard for the diagnosis in many cases. This is the view of the lesion inside the light microscope. As you can see in the right picture, there is oral mucosa, and then this is the lesion, which has a kind of bluish hue. And then beneath the lesion, there is the regional salivary gland structures. In the left picture, you can see here the secreted material and also a granulation tissue that surrounds the lesion. So briefly, you can see an area of spilled mucin surrounded by a granulation tissue and also an inflammation and foamy macrophages which are going to phage the extra mucin. So I want to ask you, do you have any idea what is the what is this lesion? This is another view of the lesion. Here you can see some foamy macrophages, macrophages who are going to phage the extra mucin that is inside the tissue. These are marked by the arrow. This is another view of the lesion. At the top, you can see the oral epithelium, and then that is marked by the red arrow is the spilled mucin, and between the oral epithelium and the mucin, you have a granulation tissue that surrounds the mucin. Here you can see it in a high power view. So my question is, what is the diagnosis? One, mucocele. Two, salivary gland tumor. Do you think? Obviously, I told you I'm gonna talk about the salivary gland lesions. Do you think it is a mucocele, or it is a tumor, or it's an infection? You can type 1 for mucocele, 2 for salivary gland tumor, and 3 for infection in the chat box. So how can I see the chat box? Okay, Yes, as most of you mentioned correctly, the answer is mucocele. Mucocele is a kind of extravasation of mucin phenomenon that results from the, excuse me, I cannot move my slides forward. Okay. Mucocele results from the rupture of the excretory duct of a minor salivary gland. And that results that the produced mucin cannot go to inside the oral cavity, and it's extravasated into the surrounding soft tissue. And there is a local inflammation response of the host and granulation tissue formation. It is the most common salivary gland lesion that you can see inside the oral cavity. Regarding its treatment, many of the mucocele are short-lived lesions that rupture and heal by themselves, but many of them are chronic lesions that needs to be excised by the surgeon. The next case which I'm going to share with you is a 41-year-old male presenting with a swelling in his the floor of his mouth. Actually, it was not painless, but was a little tender. And the patient says that he has a little pain during its mealtime. So it's a kind of episodic pain during the mealtime. Here you can see this. And in the radiographic view, you can see that the lesion is radio opaque in the floor of the mouth. So it was excised, and in the right picture, you can see it. It's a calcified material. And regarding its histopathologic feature, you can see in the left picture that is a kind of lamellated calcified material. So what is your diagnosis? I didn't give you some choices because it's very, it will be so much easy. So you can type in the chat box your answers, what you think it is, this calcified material in the flora of the mouth of the patient. The patient had no pain except for the mealtime.
The diagnosis.
So it is Sialolithiasis, salivary calculi, or salivary stone. As many of you knew, it arises from the position of calcium around a nidus inside the lumen of a salivary gland, and it can be promoted by chronic sialodenitis. On the other hand, it cannot itself promote sialodenitis in the corresponding salivary gland tissue. And the most important part that it is not related to any systematic dysregulation of calcium and phosphor metabolism. It can occur in minor as well as major salivary glands, and it's the most common site of involvement is submandibular gland duct. But also it can occur in the minor salivary glands, especially upper lip and buccal mucosa. So regarding its treatment, if it is, it can be treated by gentle massage of the gland toward the ductal orifice. You can use cyanogogues or moist heat to increase fluid or increase fluid intake to increase saliva production, and it can be helpful to pull out the calculi. But of course, in some cases, it needs for surgical intervention. And in these cases, in minor salivary gland, you have to take out the associated glands as well. The next case is a male, is a 43-year-old male. He presented with a painless expansion in the lateral portion of the hard palate for 6 months duration. The lesion was excised by the surgeon. As you can see, the growth of the lesion in the left picture, it was a solid mass partially surrounded by a capsule. In the right picture, you can see a picture of its histopathologic feature. As you can see, the lesion is partially surrounded by a capsule. In this picture, you can see a part of the lesion that you can see some chondroid stroma inside it. As you can see, this is how the chondroid material looks like under the light microscope. So a part of like a nodule of chondroid material and an area of other tissue with fibrostroma. Here you can see that an amorphous hyalinized material is there in the stroma. It is called hyalinization of the stroma. And also you can see some ductal structures, as you can see them here, are scattered through the lesion within a hyalinized stroma. And inside the ducts, you can see some secreted material secreted by the ducts. This is another part of the lesion. As you can see different views of in different parts. It doesn't look similar in all the fields. Here you can see a mixed stroma, a loose stroma, and scattered stellate-like cells are, you can see inside this, and also some duct-like structures lined by multiple layers of the cells. These are another feature of the lesion. These are plasmacytoid cells. Originally, they are myoepithelial cells, look like the plasma cells. As you can see, there is an oval cytoplasm and a laterally located nucleus of the cell. If you could see this picture, then you're lucky, because it could be very much helpful in the diagnosis of this lesion. So in some areas, you can see a fibrostroma, scattered ducts, and also some nests of myoepithelial cells that some of them were plasmacytoid. So these are the choices. What do you think the diagnosis is? Do you think it's a tumor or it's not? And if it's a tumor, is it a squamous cell carcinoma originated from the overlying oral epithelium, or is it a pleomorphic adenoma, which is a benign tumor of salivary gland origin? Or it is necrotizing sialometaplasia, which is a non-tumoral lesion? What do you think it is? So here you can see the pictures again. A chondroid material, many ducts, hyalinized stroma, duct cells, myoepithelial cells, that some of the myoepithelial cells are plasmacytoid. This is pleomorphic adenoma, which is the most common salivary gland tumor. Actually, the most common site of involvement of pleomorphic adenoma is parotid gland, but of course it can occur inside the oral cavity, and inside the oral cavity, the most common site, one of the most common sites of involvement is hard palate. So you may see these lesions while practicing as a dentist inside the patient's mouth. It's not uncommon. Pleomorphic adenoma, as mentioned, is the most common benign salivary gland tumor. and it presents as a slow-growing, non-painless mass, usually in the hard palate. So if you had such a lesion, one of the most common differential diagnoses that you should think of is pleomorphic adenoma. So this is a case for a young lady, she was referred to our clinic. She had, you can see here, she has a lobulated mass in her retromular area. The mass was lobulated, a little bit ulcerated, and the surgeon excised the lesion. The differential diagnosis of the surgeon was pyogenic granuloma, which is a common non-tumoral lesion of the oral cavity. So it is, and honestly, it looks like really like a pyogenic granuloma. The lesion was excised by the surgeon as he thought it is a reactive lesion, non-tumoral, just a reactive lesion. And that is what we saw under the light microscope. Here is a view of the lesion. You can see some big cystic spaces lined by some cells which cannot be seen this power. Here is a high power view of the lesion. As you can see, there are some cystic spaces lined by a mixture of mucus cells and epidermoid cells. The mucus cells here you can see are tall columnar cells with a foamy cytoplasm. And inside the cystic space, you can also see some secreted material produced by these cells. So as you can see, most of the lesion, or better to say the tumor, is most of the tumor is composed of mucus cells, but there are also scattered epidermoid cells as well. Here you can see these two types of the cells in this picture. In the left side, you can see mucus cells appear like a tall columnar set with foamy blue cytoplasm, and in the right side there are some small cells with eosinophilic cytoplasm arranging as small nests. So the diagnosis. What do you think the diagnosis is? Do you think it is a malignant lesion or a benign lesion? Do you think it is a not tumoral lesion or actually a tumoral lesion? What is your idea about it? May I have the chat box? May I see the chat box? So if you think it is a malignant lesion, you can send, okay, this is the answer. You can send 1 if you think it's a benign tumor, pleomorphic adenoma. Send 2 in the chat box, or if you think it's mucosal, as you can see, there are lots of mucin-producing cells lining the cystic spaces. Then you can type 3 in the chat box. Okay. As mentioned, the correct answer is mucoepidermoid carcinoma. It is a malignant. It was really a malignant lesion. The case was a true case, not artificially. It was a true case. The mucoepidermoid carcinoma, a malignant salivary gland tumor that presents itself clinically as a benign lesion inside the oral cavity. So what I'm gonna tell you in this case, add in this case, is that there are some places inside the oral cavity, including floor of the mouth, including retromolar area, and tongue mucosa. These places are not common places for salivary gland lesions, but if there is a tumor originated from salivary gland in these three areas, retromolar, floor of the tongue, floor of the mouth, and tongue mucosa, then most probably it is a malignant lesion. And in the other hand, many mucoepidermoid carcinomas, which are malignant salivary gland tumor, can present clinically as a benign lesion. They can clinically they can mimic mucocele. The first case we discussed about was a mucocele. They can have the same appearance as mucocele, or they can present as a benign reactive lesion like pyogenic granuloma. So if you have a case of a mass even if it looks like a benign or reactive lesion in these areas, be careful and have in your mind that it might be a malignant lesion of salivary gland origin. So I would like to thank you for your time. And if there's any question, I'll be delighted to answer.
Thank you very much, Dr. Mahdavi. Okay, do you have my voice?
Yes, yes, of course.
Thank you very much for your interesting presentation, and I hope the audience would enjoy your nice practical presentation. I know that dentists commonly cope with such lesions during their clinical experiences, and I would like to invite all audience to have review of what you explained in your presentation, especially salivary gland lesions. Thank you very much for your time. And I would like, do you have any comments, Dr. Mahdavi, to add? Or
No, just this word that I do appreciate, dentists who spend so much time on having a very good restoration on the patient's tooth. But at the same time, please take a look at the surrounding tissue. There may be some lesions that you can see them and save the patient's life. So if you don't know what to do with this, it's okay. Just refer the patient. Thank you very much.
thank you for your presentation. And I would like to invite our second speaker, Dr. Darakhshan. I think she's with us. Shall we have a short video? Okay. Okay, we will join Dr. Darakhshan after 1 or 2 minutes after a short video. Please stay with us. We will be with Dr. Darakhshan in 2 minutes. Okay, thank you very much again, all audience, for being with us. I would like to introduce my colleague, Dr. Samira Darakhshan. She is oral pathologist in oral pathology department of Tehran University of Medical Sciences. Additionally, she is mentor of our undergraduate students in dental school. Thank you, Dr. Darakhshan, for accepting our invitation in this course, and the platform is yours.
Hello, Dr. Shakib. Thank you for you. Good afternoon. I would like to introduce myself. I'm Samira Darakhshan from Department of Oral and Maxillofacial Pathology from TUMS School of Dentistry. Today, I'm here to speak about neoplasm of oral cavity. Neoplasm of oral cavity are a wide group of the lesion that we face to them in clinic. And first, we classify the neoplasm of oral cavity to groups of epithelial origin, mesenchymal and salivary gland origin, and odontogenic origin. And also we can face to other lesions, tumor-like lesions. The main of them is a reactive lesion that they are not a true neoplasm of oral cavity and make a tool-like lesion, and also metastatic lesions in oral cavity we can face with them in clinic. Generally, the tumors of oral cavity classifies as two groups of benign and malignant lesion, as you know, and some the clinical features and properties of these tumors or neoplasm can help us to differentiate them and to lead to make a definite diagnosis. But some of the clinical features may be mislead us, and we cannot differentiate between the lesion. We can face to such a small lesion in an area of tooth extraction, and also the lesion maybe have an intact surface, and instead, unlike the previous slide, we can face to this huge lesion in the clinic. And it's very important to be aware about the management of this patient and get assurance to the patient about the nature of benign and malignant nature of this lesion, and to help the patient. Generally, some clinical features has belonged to the benign lesion, and some of them are belong to the malignant lesion. The benign lesion usually are well circumscribed, small in size, slow-growing, encapsulated lesion, and usually are non-invasive. And there are any hemorrhage and also necrosis in benign lesion, and the benign lesion, as you know, have not metastasis. And unlike the benign lesion, instead of malignant lesion are not well circumscribed. Usually they are larger in size, fast growing, they are non-encapsulated and invasive and infiltrative to the surrounding tissue. And we face to hemorrhage and necrosis in some cases, and the malignant lesion can have metastasis. And also we should be aware about the traumatic lesion that can be faced with them in clinic. You can see in this slide 14 years old teenage that reported trauma from slightly hitting a pen in the right buccal mucosa from the pressure that he has about a hard exam, and the chronic pressure of this pen can lead to this ulcerative, fissurated lesion in the same area of the trauma. And also we had a 47 years old female with, she reported that she received a partial denture for premolar, maxillary premolar tooth, and he bite her tongue, and this lesion appeared after 2 weeks after they received the denture. It's very important to be familiar about the traumatic ulceration in oral cavity that can occur and maybe mislead us and make a mistake about us. In the next slide, you can see a clinical feature about a lesion that was pedunculated and has intact surface with a dark red light in the area of interdental papilla, in area of canine and first maxillary molar teeth, and the patient reported the duration of this lesion about 3 months. And as you see in the right side, the radiographic feature of this lesion in the same area, we can see the a slight or mild radiolucent lesion in intraradicular area in the underlying bone. And as you see in this slide, the first clinical differential diagnosis was pyogenic granuloma or peripheral giant cell granuloma, which belonged to the reactive lesion category. And after excisional biopsy of the lesion, peripheral giant cell granuloma was confirmed, and you see the proliferation of spindle cells admixed with giant cells in a hemorrhagic background. And in this slide, you see the completely healing of the lesion in clinical view and also in radiographic view of the cases about 2 months after the excision. Also, we had a case with this clinical feature that you see in this slide, and I'm sure that you confirm me that it's very similar to the previous cases, but maybe the lesion is very darker in color, and also we faced about 50 years old female. And as you see in this slide, the lesion is hemorrhagic, is very easily hemorrhagic, and unfortunately in excisional biopsy of the lesion, we face to this this uncomfortable view of the histopathologic lesion. We face to a proliferation of the spindle cells that they are very dysplastic, they are very huge in size, and show and demonstrating pleomorphism and numerous atypical mitotic figures, and also basal cells admixed with melanin aggregation, as you see in this slide. And after ancillary study of melanoma, we confirm diagnosis of malignant melanoma after, as I said, the diagnosis of malignant melanoma. You confirm me that the lesion and the future of the patient is very important when we think about the differential diagnosis. And it's very important that we should be aware about this. In the next case, you can the lesion in area of mandibular alveolar ridge with a papillary white surface, and the patient was the 34 years old male, and reported the duration of about 6 months for this lesion. I'm sure that you confirm me that for this lesion, that the clinical feature is not very proper for a reactive lesion. We also should be have a proper radiographic feature of the lesion. And as you see in this slide, the radiolucent lesion in area of underlying bone with some sclerotic border, especially in posterior area, is evident, and the aspiration result was negative. In these cases, you confirm me that reactive lesion have not any behavior like this, and maybe some more aggressive lesion be in differential diagnosis like ameloblastoma, and incisional biopsy should be done. And as you see in this slide, the sheets of ameloblastic-like cells with core of the nest that's mimicking stellate reticulum, and the columnar palisaded cells with reverse polarization is evident in the periphery of the nest, and the diagnosis of ameloblastoma was confirmed. In the next case, we faced this endophytic ulceration in area of hard palate, and the lesion has the ulcerated surface and necrotic surface, and confirmed me that such lesions, such squamous cell carcinoma, and also the lesion with salivary gland origin should be considered in area of hard palate and junction of hard palate and soft palate also. And the radiographic lesion showed a lytic radiolucent lesion that mimicking inflammatory or infectious lesion like osteomyelitis, and incisional biopsy was confirmed to the patient and conferred the diagnosis of squamous cell carcinoma. As you see in this slide, sheets of dysplastic invasive dysplastic cells with squamous origin and numerous creatinine cells. The next case, as you see in this slide, is very interesting about the diagnosis, and we report this case. This case was 34 or 5, I think, years old female that referred to the oral and maxillofacial surgeon with this lesion. You see the slightly or mild swelling in maxillary gingiva in area of premolar teeth, and as you confirm me, the oral hygiene of the patient was good or also very good, and the reactive lesion should not be considered because of the oral hygiene of the patient and also the clinical feature of the lesion. And as you confirm me, we need to radiographic feature and evaluation of these. And you see in this picture, radiographic feature of the patient and the radiolucent lesion with ill-defined borders was evident in the area of the lesion. And also there is an important point about the widening of the periodontal ligament in this radiographic feature. Incisional biopsy was done by a surgeon, and we faced this uncomfortable pictures in histopathologic evaluation. And as you see in this slide, there was proliferation of spindle and oval dysplastic cells and strap pattern in some area, and numerous atypical mitotic figures, and also basal cells that by IHC or immunohistochemistry study by positive immunoreaction for MyoD1 and myogenin, we confirmed the diagnosis of rhabdomyosarcoma. And you confirm me that rhabdomyosarcoma is very rare in oral cavity, and we report this case in dental journal, I think. And but this rarity is not a good reason for ignore a lesion, and it's a very important point that dentists should be aware about this. The next case was the 50 years old male with a very good lifestyle, and also presented with this large lesion in the area of hard palate with lobulated and hyperkeratotic white surface. And as you confirm me, this lesion is not blind to a reactive lesion because of the color and lobulated. Also, the pyogenic granuloma or peripheral giant cell granuloma can be with lobulated surface, but they are hemorrhagic and red in color, not white. And because of this region, and also you can you know that in hard palate the salivary gland origin tumors should be considered in differential diagnosis. Because of this reason, the incisional biopsy was done, and we faced a clear cell carcinoma, invasive clear cell carcinoma. And you know that clear cell carcinoma can be could be belong to the salivary gland origin, but by ancillary study, the origin of salivary gland was not confirmed, and we should to evaluate the patient for the metastatic lesion with clear cell feature from another distant origin. And we suggested the PET scan for the patient, and as you see in this slide, hypermetabolic tumoral lesion was seen in left kidney of the patient, and the patient was gone to the oncology department, and the chemotherapy was done for his, and it's very interesting for us that the huge lesion in oral cavity without any surgical intervention was disappeared by chemotherapy, and it's very important for us to select the best for the patient, and to select the best treatment plan for the patient. Unfortunately, we have another metastatic lesion in oral cavity in our department, and as you see in this slide, the patient was referred from a general dentist that unfortunately he ignored the patient, and also did the dental needs for the patient, and all anterior teeth of maxilla was done root canal therapy, and because of the persistent pain and pus discharge from the area, the patient was referred to a surgeon, and finally the CDCT was done, and as you see, a large lesion with a perforation of and many surrounding bone was evident in the CDCT. And also for this patient, we suggested the PET scan, and you see the report of the PET scan that metabolic activity was seen in the left kidney, and also the metastatic nature of the lesion was confirmed. It's very important to aware for us that also it's a true fact that the metastatic lesion is very rare in oral cavity, but as I mentioned before, rarity is not a good or a proper reason for ignore the lesion in oral cavity based on the rarity of the lesion. In the next case, you see a panoramic view for about, I think, 29 female that we reported for us and referred to us by a dental that came out from the socket. And what happened? What did happen? The patient referred to a general dentist by this panoramic radiography, and you see in the area of second molar tooth, mandibular second tooth, and the radiolucent area that are in the both side of the tooth, and the dental caries is very limited, and the oral hygiene is very good, and also the dentist ignored the radiolucent area and started to treatment this tooth for the negative vitality test, and during the process, during the root canal therapy, the whole of the tooth came out the socket, and also you can see the tooth here and the lesion which attached to the CJ area and also in radicular area of the tooth. The diagnosis of this lesion was confirmed plus mastocytoma, and the patient suggested to work up work up for the rule out or rule in the any distant bone involvement and rule out or rule in the multiple myeloma. And this ignore from the patient, from the dentist, is very bad happen that can be occur. Another tragedy that I presented for you is another patient that the dentist did respectively root canal therapy for the mandibular anterior teeth, respectively continuously. And as you see in this slide, there was a cystic lesion in anterior area of the mandibular bone, and because of the lesion was painful, and because of the persistent pain, the patient was referred to a surgeon to make a definite diagnosis. And the surgeon did excisional biopsy for the patient and faced it with this picture about bloody spongy, or that you can see in this picture, and the surgical impression was CGCG or central giant cell granuloma, and also ABC or aneurysmal bone cysts that can have this appearance in gross examination. And the diagnosis of ABC or aneurysmal bone cyst was confirmed in histopathologic evaluation. And you could see the treatment which the patient received for this pathologic lesion in his mandibular bone, and mistaken that the dentist done. I return back to the one of the first slide, and you see a patient with this huge tumoral lesion in the maxillary jaw. And before this picture, the patient have this lesion in the hard palate, and you can see also a black silk stitch in this area. The photo has been taken after the incisional biopsy, and before them, because of the personal problem of the patient, he ignored the lesion, and after the incisional biopsy, he don't turn back to the dentist for getting the pathologic report, and the lesion grows fast in this size, in this huge size that you see in this slide. And you can see also in this radiographic view of the lesion that the ill-defined radiolucent lesion was evident in the underlying bone of the lesion. Unfortunately, we see in the histopathologic evaluation of the lesion the shift of a small round cell that can see foci of necrosis among them, and finally with ancillary study or via a immunohistochemistry study and positive immunoreaction for CD99, the diagnosis of Ewing sarcoma was confirmed, and the patient undergone to the best treatment plan. But unfortunately, we lost the patient about less than 1 year. Finally, in the last picture that I prepare for you in this presentation, I would like to mention about some lesions that may be rare in oral cavity, like the cases I reported. And you see in this slide the generalized hyperplastic area or gingival hyperplastic areas in oral cavity in anterior area of maxilla. And this slide is a typical or a common view of leukemia appearance in oral cavity. And this malignant lesion maybe mimic some reactive lesion or tumor-like lesion in oral cavity, and it's very important for us to know them and be aware about them to do not make a mistake and do not mislead us this clinical feature. And also I suggested that the incisional biopsy for this lesion is very, very important to rule out any malignant lesion. Thank you for your attention. I'm here for any question if you have.
Thank you, Dr. Darakhshan. Do you have
Thank
my
you.
voice?
Yes, yes, Dr. Shakib.
Thank you very much for your nice presentation, and also in some cases tragic, I think, cases, but it is a great, it is a great hint for us to be well aware about all kind of lesions in oral cavity. And I would like to invite all audience to meticulously examine the patients during their practice, even dental practice. I think a patient is a whole body, including buccal mucosa, including tongue, palate, and other parts of the oral cavity. And we should not just focus on tooth to treat dental caries or something like this. And I think your presentation make all of us aware about what we should do during our routine examination. Thank you very much.
Thank you from you, Dr. Shakib. Yes, it was very tragic and unfair, or I honestly say it's very unprofessional act with the patient.
Okay, hello everyone again, and I would like to invite my colleague, Dr. Karduni, for the last presentation of the first day of virtual winter school program. Dr. Karduni is my colleague in oral pathology department, and thank you for accepting my invitation, Dr. Karduni, and the platform is yours.
Thank you. Thank you, Dr. Shakib, for your comprehensive introducing me. And I would like to say hello and good afternoon to all audience. First of all, let me introduce myself. I'm assistant professor, and I work at the Tehran University of Medical Sciences, and I want to apologize in advance for not being able to remove my face mask, and hope you are not getting tired right now at the end of today's program. And as all of you know, I'm the last speaker, and I want to give you some information and share with you some of our cases in our department, and hope all of you getting with any level of pathological knowledge will have a comprehensive view about the oral pathology field and our cases in Iran. Okay, to make the long story short, let me to go to the first case, the main point, which are the cases. The first case which I'm going to introduce for you is a 40-year-old female or woman with the chief complaint of purulent discharge from left posterior of mandible. On physical examination, an expansile lesion in left side of mandible was found, and the patient reported no neurosensory disturbances of the lower lip and chin. The left first molar had grade 3 of tooth mobility. As can be seen here, we have the patient's intraoral image with a surgical view or approaches at the surgery room. Okay, the panoramic view, as can be seen here, showed a radiolucent lesion at left angle or body of the mandible at posterior area, which involved the posterior molar roots and caused root resorption for the first molar tooth. As it is evident, there is an impacted tooth within the root of first and second premolars. And I think no more information we can get, no further information we can get from this panoramic. And let's go to the CT scan. The CT scan of the patient showed a radiolucent lesion as well as posterior area, and with more prominent root resorption even in the second premolar tooth at that region. And in some cuts, I mean, in some of them, you can see some internal structures, including radiopacities within the lesion. So at this time, you can conclude some of your differential diagnosis regarding to the patient's history and his or she's radiographic findings. Okay, finally, the surgeon referred the specimen to our pathology lab, and this was what we seen. A surgical specimen which composed of gelatinous and also dense tissue and 2 extracted posterior left teeth of mandible. Okay, at the time of pathological examination, these slides were what we can found. We found that 2 components were mainly seen. The first one was a cystic component, which can be seen in more magnification. In the right-hand image, you can see a cystic tissue lined by oral epithelium with reverse polarity at the basal cells and tall columnar palisader cells, and somehow loose slate-like cells at the superficial level of epithelium, and sheets and aggregates of eosinophilic amorphous materials, which resembles goat cells. And by the definition of the odontogenic cyst, may I ask you which cyst is in your main differential diagnosis or in your main definite diagnosis at this time? May I ask the IT woman to prepare for me the answers, and can I see the answers? COC, well, right. I think you are completely right, and I will go and show you more pathology sections, and serial sectioning of the specimen reveals such a sheet of neoplasm. By more magnification, you can find this neoplasm over there. Okay, may I have some of you active, and may I ask you to explain what you are going to, what you are watching, or what is these this neoplasm. Thank you for chemia, odontogenic cyst it was. And this is another part of the lesion. As can be seen, it is not a cystic lesion. It's completely solid in this slide, and it's composed of ovoid cells at the background with some islands and nests of odontogenic origin. Can be seen the reverse polarity, even the stellate reticulum cells in the center. And again, I want to ask you, what is your definite diagnosis regarding only to this section, without the previous consideration about the COC? Can you tell me what kind of odontogenic neoplasm could be considered based on this section? OKC. About the previous section, which was a cystic tissue, I agree with you, and this is a cystic lesion with ghost cells and reverse polarization of the basal layer with loose to vascular background in the cyst wall. The COC, I think, fulfilled the whole criteria of this lesion, but what about this section? After multiple sectioning, we found that the specimen is not only a cyst, it is composed of two components, a cyst and a solid neoplasm. The solid neoplasm composed of, as I mentioned to you, neoplasm composed of ovoid cells in background with odontogenic epithelium and reverse polarization. To make the story short, I found that it may be a neoplasm with ameloblastic origin, and ameloblastic fibroma could be good for the diagnosis of this section. After the reviewing the literature, okay, this panoramic view revealed the patient's panoramic image after 6 months following the surgical excision, and it whole thing are good and no recurrence, nothing happened. Okay, as I asked you for the differential diagnosis, let me go forward and give you my history about the search within the literature. I was searching about the COC with a neoplastic ameloblastic tissue, ameloblastic origin. And I found that, as it's written in our textbook, COC could happen in association with some of tumors and even odontoma or cyst. And I found good review literature that it was written in 2016 and showed that few cases happened in male in posterior area of the mandible with tendency to the mandible, and some of them showed the symptoms equal to our patient. And I found that okay, it could also okay with our patient, and we reported as a case of hybrid tumor, and we published it in a dental journal as a hybrid odontogenic tumor of calcifying odontogenic cyst and ameloblastic fibroma, and with the literature review also. And I hope it was interesting for you, the first case. If there's any question, I would be happy to answer or to hear from you. Okay. Is there any question? Okay. Let's go to the second case. The second case is a 40-year-old woman referred to our department with chief complaint of intense lower facial pain and aggressive swelling in left parotid for 6-month duration. Okay, may I ask you, I see one question. What's your advice to decrease the lesions in our mouth? For the reducing of the occurrence of the lesion, maybe we cannot do anything, but for the recurrence or for the outcome or for the prognosis of the patient, we are responsible to do short-term follow-up, and close follow-up of the patient is highly recommended in this case. And I think after the reviewing the literature, I found that complete surgical excision is more than enough for the patient. So don't be worried about the recurrence. Just follow your patient and be with your patient in close contact. Hope my answer will be enough for you. But for the second case, the panoramic is belongs to the second case, which was a 40-year-old woman with such a lesion, intrabony lesion, and the lesion was located also in this case in the posterior area of the mandible, and it was a radiolucent lesion with involvement of the posterior tooth roots. This is more ancillary studies. I mean, and these are MRI and CT scan of the patient, which is more than my knowledge, but as can be seen here, and I think it's obvious, the both palatal and buccal cortex of the mandible was involved and destroyed by the lesion, and the inferior, even the inferior cortex of the mandible is resorbed, and we can suggest a somehow aggressive behavior of this lesion according to these graphics. This is the patient's surgical image, and very heavy surgical procedure were done for her, and I will not go through the surgical methods. Hope you agreed with me. And this specimen finally was referred to our lab, and we found such a tumor or neoplasm composed of I agree with you. The malignant appearance of the neoplasm is somehow evident according to the radiography. And here we have the pathologic sections, H&E stain sections. The photomicrograph, as can be seen here, are showing neoplasm composed of sheets of solid sheets of the tumor with central necrosis, and I think all of you can see the dystrophic calcification at the top of the right-hand slide. The dystrophic calcification is extended through whole lesion, and even you can see at the tumoral cells some nuclear atypia and pleomorphism. And this is more magnification. With the more magnification, we can see more details, as can be seen. The peripheral cells showing palisading, reverse polarity, and at the right hand again section, a very large nucleus with atypical bizarre shaped cells can be seen, and the diagnosis of malignancy is more probable based on these histologic findings. What kind of malignancy? Which calcification can you conclude for this patient? Does it fulfill whole criteria of malignant ameloblastoma or ameloblastic carcinoma or malignant pinball tumor? And squamous cell carcinoma, somebody has written. About squamous cell carcinoma, we don't maybe have this peripheral palisading regarding to this malignancy and reverse polarization of the peripheral cells. But it's looked like somehow this squamous differentiation. I'm very thankful for you for your answer that you got the point that some squamous differentiation is done in this tumor, and but it's not going to fulfill whole criteria of squamous cell carcinoma or squamous cell differentiation of this tumor. Okay, and according, the reverse polarity is very, very important in the basis of the odontogenic neoplasm. And we are very aware about the ameloblastoma and its derivatives. So I think we did more investigations, and we did IC for this case. And the Ki-67 was slightly hard, especially in peripheral cells, as can be seen here. What about the calcification? Do we have any calcification in ameloblastic carcinoma? Does somebody hear about the calcification in malignancies of odontogenic origin? Again, to make it briefly and quickly, I will tell you that after the reviewing of whole English literature, I found only 2 cases has been reported in radiography, even not in histology, that ameloblastic carcinoma can resemble radiopacities within the OPGs. After that, I searched too many textbooks, and I didn't find anything about ameloblastic carcinoma with calcification. I did some consultation with our colleagues in Cancer Institute, and nobody told me nothing to differentiate about ameloblastic, these 2 entities, the ameloblastic carcinoma with calcification and malignant Pinburg. The patient showed me multiple biopsy reports in multiple centers over the city and even over the Iran, and it was diagnosed previously as a malignant Pinburg tumor. As all of you know, the Pinburg tumor is rare neoplasm, odontogenic neoplasm, and the malignant Pinburg is extremely rare. And after that, I did some staining, only the chemical staining, not ICs, regarding to congruent, and I found it was negative regarding to amyloid or some materials secreted between cells. And I was taught that maybe these materials are amyloid and the calcification is occurring on the base of these materials. But when the staining showed the negativity result, I found that no, so it's not a malignant Pinburg, and these materials are not amyloid. That's why I call them dystrophic calcification. And fortunately, I could publish it in a Journal of Case report in an ISI indexed journal as a ameloblastic carcinoma with calcification, a rare case report in Mandible and Literature Review. The reviewers were very, very interested with our case, and fortunately, we didn't pay any charge for the publication. Okay. Okay, let me see the chat box. It's written that ameloblastic transformation of the cells Yeah, there was a reverse polarity over there. And Pinberg radiograph would show a dry venous node opacity. As can be seen, there was somehow opacities in radiographic image, but as all of you know, the dry venous node opacity can be seen only in panoramic view, not in slices of CT scan. And on panoramic view, it was not that much obvious, the opacities. But the calcified material under the microscope was really evident, can be seen here. Through a whole lesion, it was extended. Okay. The last but not least case is a 70-year-old man with mandibular intrabony lesion and previous diagnosis of low-grade gland-forming tumor. This is the panoramic view, what I had. And can be seen the quality is not that much good, but at the body of left mandible, a radiolucent lesion can be seen with destruction of the mandibular ridge and the angle. Okay, the specimen was referred to our lab as well, and this is what we saw. I would go through the microscopic sections, and I would ask you to conclude after that and give me your final diagnosis based on histomorphologic findings. By more magnification. Okay, and I did some IC studies regarding to the case. The cytokeratin 19 was strongly positive, P67 as well. The nuclear staining and positivity is revealed here. And the Ki67 staining, which is not inconspicuous or not ignorable. And the cytokeratin 7, which is low molecular weight cytokeratin. And I want you to conclude your final diagnosis, and please write it in chat box as it is possible for you. This is the H&E. I think most of you like to see the H&E sections. Can be seen, I think, the mitosis between the cells in the septa or within the cells, within the parenchyma tumor. And even in this photomicrograph at the center, we can see anaphase of mitosis. And let me somehow introduce it to you. This is a gland-forming neoplasm. A duct-like structure is evident in these sheets. You can see we can see more than half of the specimen or the neoplasm composed of duct-like structures. And at the center, you can see proliferation of the ovoid cells with circular or somehow glandular shapes. If somebody wants to tell me the diagnosis, I would be very happy. And I will go through the next photomicrograph. It can be seen that it's not only glandular structure, it's also composed of dizzying array structures or appearances, something that we can see in AOT, adenomatoid oncogenic tumor, but also we can see the peripheral palisading and the reverse polarity, especially at 10 o'clock of this image. At that location, you can see the reverse polarization or even throughout the specimen. So we have duct-like structure, and to conclude it, we have duct-like structure, we have reverse polarization, and we have swelling or dizzying array appearance. And after reviewing the literature, at this time, I was concluded that maybe it's a kind of ameloblastoma, but it doesn't fulfill the full criteria, and maybe it's a salivary gland neoplasm, but the reverse polarization was not acceptable for that kind of tumors. By the reviewing of the literature, me and my colleague, Dr. Shakib, I would like to thank him about this case that he gave me the case. Thank you, Dr. Shakib. And the gland-forming allogeneic tumor was evident for us, and we found that adenoid ameloblastoma with significant proliferative activity is best term for describing the lesion. And finally, adenoid ameloblastoma was signed up for the patient, and a note or comment was written that adenoid ameloblastoma in literature is mentioned that showed aggressive behavior, and there is a tendency to recurrence for this tumor. However, the literature is very, very little and subtle for this tumor, and we need to follow our patient to get the point of prognosis. The literature is not showing you a bright prognosis at right now, but by following your patient, you may lose nothing. So the surgery is only therapeutic approach for this lesion, the adenoid ameloblastoma. And I think the surgeons, as it's written in the literature, they also have some inconfidence in therapeutic approaches with the patient, as we did in the pathologic aspects. And finally, I would like to thank you that being patient with me and being active even in writing in chat box. And I would like to wish you being healthy and not getting infected with this insidious coronavirus as well. Thank you so much and have a good day. Thank you. Bye-bye.
Thank you, Dr. Karduni, for your impressive presentation, and thank you for being on time. According to Tehran local time, it's 4 p.m. and we stuck to the schedule. And thank you very much for sharing your experiences and interesting cases with us. And I would like to express my appreciation with all audience. And this is the end of the first day of virtual winter school program 2021, organized by Tehran University of Medical Sciences. Okay, at the end of the first day, I would like to invite all the audience to turn on their video webcam to have a group photo of the first day. Would you turn on your video, all audience? We are going to have a memorial photo, group photo from the first day. Okay, thank you for turning on your webcam. Great, nice to see you. Thank you for being with us until this time. Thank you very much. And we are ready to have a group photo. Thank you for being with us.
Thank you.
And this is the end of the first day. I would like to invite you to be with us tomorrow morning. And I'm sure we have scheduled interesting presentations for tomorrow morning. Have a nice day, and please be in touch with us via email and WhatsApp also. Thank you very much. Have a nice day. Have a nice
Have a
day.
nice day. Bye-bye.
Bye bye.